Hello, everyone. Welcome to Retina Synthesis. I'm here today with my colleague and directing this webcast, Dr. Charlie Wykoff. Charlie, how are you today?
Carmen, great to be here with you to talk about some exciting data.
At the AAO, you gave the second year first results on a suprachoroidal gene therapy program for diabetic retinopathy, nonproliferative diabetic retinopathy.
Yeah.
But before we discuss your results, why don't you give the audience your perspective on the dilemma, the treatment dilemma facing clinicians when it comes to non-proliferative diabetic retinopathy without macular edema.
Yeah, great topic, and something I see a lot of in clinical practice, as I think every retina specialist does. We're in this situation where we have a couple drugs that are good drugs that are FDA approved for the treatment of this scenario that you described, NPDR without DME, and yet they're rarely used, right? The patch survey year over year shows that a small percentage of retina specialists globally use the anti-VEGF agents for the treatment of diabetic retinopathy, again, without DME. And yet the problem still persists, right? We've known for years that diabetic retinopathy and its many manifestations is a leading cause of vision loss and blindness worldwide. And we even have data in the anti-VEGF era, fascinating analysis published in Diabetes Care, looking at development of sustained blindness, so permanent blindness, among patients that were diagnosed with diabetic retinopathy during the anti-VEGF era. And in that time frame, baseline diabetic retinopathy severity was a strong predictor of the ultimate development of blindness 5 years later. So that's in the context of most doctors that say, well, look, I'm going to wait until PDR or DME develops to treat it. And I do the same thing in clinical practice in most cases, but we are missing an opportunity because some of these patients do go on to lose significant vision. And we know that more severe DR at baseline is a predictor of that. And, we also know that this is not a new opportunity, right? Many different oral agents, topical agents have been tried in really good trials to find a way to prevent the progression of DR to DME or PDR. And right, all the big pharma strategics have invested in this and have trials that have, in most cases, been unsuccessful. And so this is clearly an unmet need, clearly something that has been invested in the past. And so still very interested in finding something that can be a doable approach to treating these patients. Because it's pretty clear that in clinical practice, a shot, even if it's a shot every few months, is not going to be sustainable. We either need something systemic that's safe, topical that's safe, or potentially, in this case, a gene therapy that might be a one and done.
Tell us a little bit about the gene therapy,
Yeah,
the
so this
agent.
Right. So this agent is called Suravec. It used to be called RGX-314. So this is an AAV8 based gene therapy that is designed to produce an anti-VEGF Fab, very similar to ranibizumab. Right. This is the same agent that is in the global phase 3 clinical trials, Ascent and Atmosphere, that REGENXBIO and AbbVie are developing for the treatment of wet AMD in Ascent and Atmosphere. In the context of wet AMD, in those global phase 3 trials, it's being given in a subretinal approach during a vitrectomy procedure. You make a bleb in the inferior periphery, and then those eyes now have really good data from earlier trials showing consistent anti-VEGF production. So we know this gene therapy works in humans, and this phase 2 trial is called Altitude. It's in diabetic retinopathy patients, and it's not given by subretinal injection. It's given in the office in a suprachoroidal approach. So it's using that original clear side needle, which is perpendicular to the scleral surface, and you inject it into that potential space, the suprachoroidal space. It expands that space and progresses posteriorly and circumferentially to coat the choroid and the overlying RPE. And then the theory is that you create a local biofactory that produces this anti-VEGF Fab. So that's the context, and the trial itself is a phase 2 trial, and I'll give you the design. So it was a randomized trial. So patients got randomized to observation or the gene therapy. Day one, patients got that single treatment of gene therapy and were then followed through 1 year in the altitude trial and then continued into the long-term follow-up study. And there were 3 dose levels that have been assessed. So dose level 1 was 2.5 times 10 to the 11 genome copies per eye. Dose level 2 was 5 times 10 to the 11th. And then dose level 3 was 1 times 10 to the 12th genome copies per eye. And the reason I call those out is we've learned that dose is important in gene therapy, and these different dose levels used different prophylactic steroid regimens. So the first 2 dose levels did not have any prophylactic steroids. And the third dose level, we gave a 7-week prophylactic topical steroid course 2. And at AAO this year in 2025, we showed the first time data for the 2-year data looking at the NPDR population across these 3 doses. And the reason we looked at NPDR is that's the population that's moving forward into a phase 3 clinical trial.
So what were the results?
Yeah, so if you look at who these patients were at first, baseline, they were your typical NPDR patients, 57 years old. They had great vision. They were 20/25 on average because, again, they could not have DME. And then they were DRSS level 47 in the majority of cases, about 83% of them, and 16% were level 53. It's interesting, 100% of these NPDR eyes actually completed the 1-year trial, and then about 70% of these eyes, or 38 of them, entered the long-term follow-up program. And what we saw through, first of all, the 1-year data showed that DRSS worsening occurred in about 42% of the control eyes, and then DRSS improvements of 2-step or more were seen in 8% of the control eyes. And if we looked at in the actively treated patients, the worsening was 0 to 17% through 1 year, and about a third of patients had improved 2 or more steps at 1 year. That was the 1-year data that's been shown before, but the new data that we showed, the 2-year data, was looking at DRSS outcomes through 2 years. And for dose level 2, we saw stability from year 1 to year 2 at about 18 to 22%. But in dose level 3, we saw an apparent increase in the proportion of patients with 2 or more step DRSS improvements, increased from 21% at 1 year to 50% at 2 years. And we did not have a control arm in year 2 because people crossed over actually and got active treatment if they were in the sham arm to begin with. So we looked at a natural history historical control, and in protocol W, DRCR protocol W, that rate was 8%. So 8% of protocol W improved 2 or more steps at 2 years compared to 50% here in the altitude trial with the suprachoroidal gene therapy, that one-time treatment. But the other way to look at efficacy is what doctors actually care about, which is not 2 or more step DRSS improvements. That's a regulatory endpoint. But what we care about is DME and PDR development. And we call those vision-threatening events. Every trial program calls them a little differently, but here they're vision-threatening events. And in this program, we saw that in dose level 3, that percent was 14% at 2 years. And again, comparing to historical controls, you would expect that to be about 50% with protocol W and Panorama at 2 years. So about a 70% risk reduction there through 2 years of follow-up, again, with a single suprachoroidal treatment.
That's amazing.
It's interesting. I think if there were a one-time potential treatment, I think that would be attractive and something that clinically could be quite useful for this patient population.
How do these results compare to the Panorama aflibercept trial?
Yeah, the proportion of patients achieving 2 or more step improvements is slightly lower at 1 year, and then similar, I would say, at 2 years. And the potential reason for that could be the dose of the anti-VEGF agent at the target tissue. So we're giving a gene therapy suprachoroidally, and the intraocular levels of the anti-VEGF protein are probably meaningfully lower than they would be after a bolus injection of aflibercept or ranibizumab given by an intravitreal injection. And so that could be why we're seeing improvements in efficacy through 2 years. We're limited by the small number of patients in this program, and that needs to be validated moving forward in a phase 3 trial, and it will be. But from the data that we have, it appears the efficacy is increasing. And maybe that's because this lower level of an anti-VEGF protein being produced locally is slowly improving DRSS levels over a longer period of time than what we see with bolus intravitreal injections.
Hmm. So what's the phase 3 study design look like?
Yeah, it's a good question, and I don't think anything has been finalized there quite yet. Although the hope is to begin enrolling this in the first half of next year, from my perspective. Although I certainly don't speak for the company in any of that regard. I think the other thing to really think about for the phase 3 trial is safety. So we had no intraocular inflammation, no AC cells, no AC or vitreous pigmented cells, no white blood cells in any of the NPDR patients in these 3 dose cohorts. We did see some episcleritis. So 20% of the patients in dose level 3 had episcleritis. These were all managed successfully with topical steroids. And we've learned in those cases, that was 3 different cases that developed episcleritis, that you want to taper these patients slowly if they develop episcleritis. And that was after a 7-week prophylactic topical steroid course. And so one possibility for the phase 3 trial is to do a longer topical prophylactic steroid course. You look at the intravitreal gene therapies, and there's 2 great programs that are ongoing in phase 3 clinical trials. I hope they're both successful, one with Adverum and one with 4D Molecular Therapeutics. And both of them are using many months of topical steroids because that's what is needed in those situations, and I am supportive of those regimens. In this case, we've seen pretty good control with the large majority of patients with a 7-week taper, but it might be worth going a little bit longer. So I don't know if that looks like 10 weeks or 12 weeks, but something a little bit longer I think might help decrease that incidence of episcleritis.
Hmm. What dose level are they looking at for the phase 3, do you think?
I think if it were up to me, I would go with dose level 3. I think
Hmm.
that's where we saw the best efficacy. I think we saw a very manageable safety profile with the 7-week course, but I think that 1 times 10 to the 12th level given suprachoroidally is probably where the sweet spot is. As we've seen with intravitreal gene therapy, right? We have some really good trials there, especially with ADVM-022 over many years at many different doses. We've learned that the inflammation related to gene therapy is quite dose dependent, as is the efficacy, I think, in many cases. And so you want to be in that sweet spot where you're effective enough, but also safe so that it can be used broadly in clinical practice.
Well, it is exciting. We know that chronic administration of anti-VEGF agents is critical in preventing these complications, and suprachoroidal delivery may be the answer. It's exciting.
I agree with you. It's a balance, right? Because most of these patients in clinical practice are asymptomatic. They're like you and me, Carmen. They come in, they can see their phone, they can drive, they can do what they want to do visually, and yet they understand that they have a problem inside their retinas. And we have drugs that are approved for that, but they're just not accepted commercially in most situations because of that burden and the risk associated with each injection. And so if we had an alternative, a one and done, or something that was extremely safe and easy to tolerate, like a pill or a drop, I think that would be tremendously valuable, and I think it would be utilized, and I think it would change the rate of blindness from DR, which would be a big deal.
Well, great. Charlie, thanks for the conversation and thanks for your collaboration in retina synthesis.
Good to be here with you, Carmen.